What I'm going to do is I'm going to tee up our experts, and they're going to tell you a little bit about the work that they do, and then we'll have time for 1 or 2 questions after each person speaks, and then we'll open it up for a broader discussion at the end. Okay? So the first person I want to introduce is Nat Swanson. She's from the City of Lancaster Bureau of Health, Outreach, and Education. She is a specialist and currently serves as the Outreach and Education Specialist for the City of Lancaster's Office of Healthy Homes. Her background is in education, as well as her experience with overcoming language and cultural barriers abroad. Now, she works closely with families of all backgrounds in the city. Nat, do you want to come up?
Hi, I'm just going to set up a timer because I am trying to squeeze a bajillion things into 10 minutes, so forgive me. I just don't want to impede on anyone else's time. But yeah, as Mai said, my name is Nat. I lived in Beijing, China for 6 years as a teacher. So I had about 3 or 4 of those years where I was still monolingual. It took me time to get that language, and as Lancaster is very diverse, that has really helped me to better reach out to people here and to kind of know what it's like to be on the receiving end of language difficulties. So we are going to touch on that a little bit at the end. I'm going to be really going over kind of our process from getting a referral to our outreach, first over the phone, then hopefully in person, and some best practices for that. Just out of curiosity, how many people are working face-to-face with residents during any kind of process? Okay, cool, awesome, great. So hopefully we'll have some good pointers here. If we have time at the end, I would love any questions or like ideas to chip in, things that you think should be said for this group. That would be awesome. So let's jump right in. So outreach, we're kind of the boots on the ground first impression for a program. So it's really important that we have a really good first connection with people when we get in touch with them. How do we get our referrals though? So I want to kind of back up to that. So it's been mentioned that we have this agreement as a city with the Department of Health. So every week I get a list sent over from them of children whose blood tests are over 3.5, whether capillary or venous. But I do want to point out that list is not for enforcement. That's just for outreach. So our office takes that, and before I start any outreach, I first talk with our health officer to see if he has any other referrals for me. Sometimes his referrals also popped up on my Department of Health list. So then I kind of know that, we're tracking things. That's good. I also get to coordinate with Mandy from Lead-Free Families. So we talk every Wednesday, and we go over my list and make sure that if there's any LGH patients on there, I'm not going to reach out to them when Mandy is already in contact. Enrollment in a program can be kind of confusing and difficult for families, so we really don't want to throw any more communication in than we have to have. So Mandy's awesome, and if we don't have time for questions at the end, if you want to find me or her or Leah or Grace, they're all just incredible people, and they do what I do as well, so I'm sure they could have a lot to say. So I coordinate with our health officer, I talk with Mandy, we kind of figure out who's going to reach out to who. Our health officer will send out enforcement letters to the homeowners or landlords of the property. We can't enforce homeowner-occupied homes. We can send the letter, encourage them to enroll in a program, but we can't enforce it. Landlords, however, are required to submit a LIRA, scope of work, contracts, and clearance within a certain time frame, and that's all spelled out in the letter. So I start with tenant outreach, and then I reach out to landlords after I find out whether or not the tenant's interested. Programs are not required, and I really, really want to stress that. They are a good resource for families, but some families are just not comfortable with applications, with giving their personal information to the government. If that's the case, we try Lead-Free Families. Sometimes they're more comfortable with sharing that with a health provider rather than the city. So it's really awesome that we have this coordination. But yeah, so I'll reach out to the tenant first, and if they're interested in our program, then I'm going to reach out to the landlord. Because I'm going to spend the bulk of my time on tenants, so I'm just going to quickly touch on landlords, and then we'll come back to tenants if that's okay. I hope we don't lose anyone. So with landlords, we have 2 kinds of conversations. If it's a non-enforced case, meaning that the Department of Health referred them, but our health officer didn't hear about this particular case, he can't approach it from an enforcement standpoint. So I need to keep in mind that this family may have not shared about the EBLL with their landlord. I need to be sensitive to that. So if the tenant's interested, then I'm going to come off to the landlord as like, hey, your tenant expressed interest in our program. We were connected with them through an outreach program that we have, and they're interested in enrolling, and I explained the whole program to them. With our program, we only require landlords to pay for 10% of the construction. We cover the lira, we cover the hotel, we cover a food stipend. They only pay for 10% of the construction. So typically landlords are pretty happy to enroll. We have a few who might have a little bit more of a, I don't know, discomfort with that. And again, we can refer them to lead-free families because their application's a bit less stringent than ours. If it's an enforced case, then they should have received a letter from the health officer. So now all the cards are kind of on the table. I can say, hey, I'm reaching out in regards to this EBLL, which you were notified about. And again, they're usually happy to have kind of a method to be compliant without having to spend all the money for the lira and remediation and relocation out of their own pocket. So that's landlords. I was going to ask for questions, but I'm just going to keep on rolling. Sorry. So tenant outreach. That first touch point is so important. In the beginning, when I started with the city back in January, conversations were a bit clumsier, and it was really hard to climb out of that hole until I kind of found my rhythm with how are people comfortable with being approached. So some best practices for that first phone call or text. Sometimes people don't call, and I send them a text if they're not answering. We want to keep that person in control. We do not want to run in and pressure enrollment. Good things don't feel good if it's being forced upon you. So we really want to make sure that they are aware that this is up to them if they want to do this. Even if their landlord wants them to do it, it's up to them. How do we kind of keep the pressure off? We want to start small. So don't start with a program. Don't run in and, hey, we're going to come to your house. We're going to find all the lead. We're going to fix it. It's free. That can be overwhelming. So what we have found works well is to offer free resources, educational time, discussions, and most importantly, a cleaning kit. That cleaning kit has been like the best tool for getting us into homes and establishing that trust of we're here to help. We're really here to just give you everything we can to help you get on top of the situation. So when we get into the home with that cleaning kit, I didn't bring it with me because I just wouldn't have time to do a whole unboxing and show it off. But it's a Swiffer mop refills for cleaning their floors for lead dust, Lysol wipes for furniture, surfaces, and then baby wipes for toys, hands, faces. And we go over how to use all of that with the parent at that home visit. Now, I do tell them when we set up that appointment on the phone, I say, look, I'm going to bring this cleaning kit. We also have a program, and I'm going to bring an application so you can look at it. If you want to know more information, I'll be there. If you want to fill it out, we can, but I'll just leave it with you so you can look it over. More often than not, I will just fill it out with them at their home. After we have these discussions, they're super interested, they're willing to apply, and we end up filling it out together. I do have cases where it's like, hey, I want to talk with my husband first or my partner, or I want to talk with my landlord more in depth, and people want to take their time and think about it. Then I just follow up every couple of days if needed, but usually they're pretty on top of it. So yeah, just remember not to pressure, but remember to talk about the importance of it and hopefully get them on board. It's kind of a fine line to walk. All right. I also wanted to address common challenges and misconceptions that we come across in our outreach. So one thing that happens very commonly is you have an elevated capillary test followed up by a non-elevated venous, but the venous is not 0. It's like a 1 something or a 2 something. And then I get families telling me on the phone, well, like, no, they're not elevated, everything's fine. We have to have a conversation there that no level of lead is safe for a child. And if there's a 1 point something or a 2 point something, that does tell us that there's lead in the environment somewhere, and we want to identify that before it gets higher. So just be aware that that's a common misconception to bump into, just kind of a non-concern about like a non-elevated level. And then we have the flip side. So sometimes we'll have parents who their child is a 3.5 or a little bit higher, and they're just heartbroken and distraught. And I'm not saying that's not a valid reaction, but they need that reassurance of, hey, this is our baseline. So this is our actionable, we're getting on it level. We're going to get on it. We're going to address it before it gets worse. But sometimes there is that reassurance needed of like a 3.5 is not ideal, but they're worried that their kid is just feeling horrible and sick all the time, and that they're going to, something's going to happen right there and then. And it's important to just kind of demystify those numbers for them and kind of explain what they mean a little bit more in depth if you come across that. Another very common misconception that happens more frequently with families who are not from the country but have recently moved here is, why didn't the doctor give my child medicine? Like, they just told me about this problem and sent me home, and they're just like distraught, like they don't understand, and like they feel like they got handed this bad news and then no resolution, no help or anything. So that conversation is a really important one to have, and I often will say that when we touch on diet. I'll say, like, diet is the medicine. Like, that's what you need to get in your child's body. These green vegetables, healthy meats, fruits, grains, things like that. So an important one to remember that, you know, we know this commonly in our field, but a lot of families don't know this and they can be confused. And then the kind of last common misconception, people are like, well, my home was already tested for lead. The city came out here, they did a lead test. And that's the housing inspection that we heard about earlier from the mayor, where they come every so often and do these lead inspections at the home. That is a swab and dust wipe test. That's not a LIRA. So some families need that clarification of the difference between this housing inspection and then a full risk assessment that's going to test every component of everything. So, all right. Another big problem that we have, aside from misconceptions, is challenges. And the two biggest ones we have are big emotions and relocation fears, at least from what I've seen. So as Ernie just mentioned, a lot of guilt. A lot of parents feel so guilty, like, this is my fault. I chose this house, or I chose this apartment, and maybe I wasn't doing enough, and I knew about lead sometimes, and I didn't do well enough, or I didn't even know what lead was. It's so important to reassure parents that this is not their fault. And I think you can't do that enough in some cases. They just need to hear it over and over that, you know what, this is just old housing. This is a problem that we're dealing with in the city, and we're trying to make it right. A lot of fear. Some parents are like, where is the lead? Like, is my kid getting lead poisoning from leaning against a wall or from sitting on the floor? And we have to talk about lead dust. We have to talk about components, friction, stuff like that. Some parents don't want a lot of details, but some parents need details. They need, like I said, stuff to be demystified and kind of like made very clear for them. And then sometimes I've come across anger that's a little more complex. Why did they let me move into a house that has lead in it? Why didn't my landlord tell me? There's rules for disclosing all of that, but not everyone reads that. And so again, we kind of have to say we're going to pick up and move on from where we are. And then relocation fears, obviously. I think that is very under-discussed, having to leave your home unattended with all your stuff in it. I bring pictures, and that I think has been a huge help. And again, like I keep saying, demystifying the process, showing what it's like when all the furniture is covered with plastic while the workers are there. We have pictures of that, and I show the befores, the afters, and the durings, because they need to know what their house is going to be like when they're not there. All right, couple notes on non-English speaking families, and then I'm going to wrap up. So with non-English speaking families, whether they're from the area, whether they moved here as immigrants or refugees, there's just a lot of extra consideration to be taken. And as a teacher, we have something called accommodations, which is that we recognize not every student in our classroom learns the same way. And some students can just take off and run with something, and some students are going to need their hands held a little bit more. And so that concept of accommodations applies across the board, but especially in these situations where we don't have an English-speaking family. So some ways that we want to kind of pay attention to that. We use a translation service called Propio. I don't know if does anyone here use Propio? Yeah, it's the best. You basically call a live translator and they translate for you on the spot. I would caution when using apps like, I don't want to name drop, but any translation app, just from having lived abroad, there were times where people would try to use a translation app to talk with me and I'd be like, whoa, like what are you saying? They're not always accurate, so just be aware of that. They're a good tool, but I would say use in moderation and be aware that they're not as perfect as a person would be in a lot of cases. So with these families, one of the best things you can do is start off with what did your doctor tell you? So I have a translator on the phone and I just say, hey, I'm here to talk about lead. What did your doctor tell you? Some people do not know what lead is. You'll hear the translator sometimes will be speaking this other language and you'll hear lead because they're not using a different language's word for lead. It's such a new concept, and I'm sure there is one, but it just might not be commonly used. So they might not even know what lead is, and we've just started lead is a metal. It used to be melted and put into paint because they didn't know that it was poisonous, and just all the way back kind of at square one. So it's really helpful to just start with asking parents, what did your doctor tell you? And then building from there rather than jumping in way ahead where they haven't been there yet. Relocation fears are especially heightened with immigrant families. There's a lot of sensitivity about their home. When I was living in China, if you'd asked me to relocate to a hotel for 2 weeks and leave all my stuff at my home unattended, I would have been really freaked out. Home is their safe space where they have their own food, their own language, they have their comforts, and we're asking them to step out of that while also telling them that that home has been poisoning their child, and that's a lot to take in. So extra sensitivity required there for sure. Immigrant families tend not to reach out as much, I've noticed, so reach out more. Like I said, accommodations, meet them where they are, check in more often. They might need that. Families who are immigrants or refugees might need that as well, but it's just more common here. So just to kind of wrap up, I'm sorry, I know I'm like 2 minutes over time. While programs are an amazing resource, just bear in mind that it doesn't mean it's easy. Good doesn't mean easy. We're the pipeline for these families. We get them enrolled, we get that house remediated, but they're the ones in the pipeline, and it's so easy when you're passing them through that pipeline to forget what it's like to be in the pipeline and how that's so, so different. We do this every day and they don't. So I just want to kind of call attention to that and just remind everyone of kind of those points. So if we have any, like 1 or 2 questions, I'm sorry, I know it talks like a million miles an hour, but I'd love to take a question or 2 real quick, if there are any.
Can I comment that I like that you said that you, with the immigrant families, like being more, just even just a little bit, just to show them that you're there to care.
Yeah, for sure. They definitely do need more touch points is what I've noticed. Yeah.
Do you have written material, education material, particularly for us, patient?
So we're actually working on that. We just got our lead education brochure translated into Spanish, Haitian Creole, Swahili, and Arabic, I believe, and we're just working on finalizing that and sending it off to printing. But if you would like to find me afterwards so I could pass that on to you once we get it, yeah, for sure. Great. If there's any other, oh, sorry.
So when you go into a home, who are you in representation of? The tenant or the, I guess, the landlord? Like,
So-
there was a fine line between the two.
We're with the city, so we don't represent the tenant or the landlord. We are with the city offering a resource. So I'm on the side of the tenant. I want them to address the lead hazards in their home. I'm also on the side of the landlord of, hey, let's help you be in compliance with things. So we're we have to stay very neutral. And we do come across times where there are tenants who are like, hey, can you tell my landlord X, Y, and Z? And I'm like, hey, I can't. But we do also, there have been instances where we've gotten into a rental where there's something really wrong. The roof is actively leaking and has been for months. The landlord's not doing anything about it. We want to keep everyone steady. So the way we'll kind of work with those things is say like, hey, this water coming into the home could potentially affect our lead work that we're doing. Can you please fix that before? Because, I mean, we have to be honest that there are sometimes situations we walk into where things aren't as they should be. So yeah, fine line to walk, but that's a great question. Okay, if we have any other questions, if we have time at the end, I'd love to hear them. If not, please come and find me, or like I said, Mandy or the Lead Free Families team, and I'm sure we could, yeah, get those answers. So thank you so much.
Thank you, Marilyn. Next, we're going to bring up Darcy Scott. Darcy is a senior policy advisor for the National Center for Healthy Housing. She's been engaged in federal advocacy for over 15 years. She has worked with a number of large-scale organizations like the ACLU and the Susan G. Komen for the Cure to influence legislators through public engagement. She ran government affairs departments for M&R Strategic Services, leveraging the power of organizations and coalitions to influence the legislative process, and her consulting clients include Habitat for Humanity and the United Way Worldwide.
Thank you so much. Hi, everybody. I think I couldn't be more opposite of the work that Nat does. I feel like, what a contrast for these two panelists going next to each other. So all the unbelievably fabulous micro things she does, I work on getting the money for at the macro level. So there were a few speakers, including Darren, and Dr. Bonacci earlier today, who specifically referred to grant pools and funds that come from the federal government, from HUD accounts, information that we get from CDC. There's EPA funds that go into a variety of projects. So the National Center for Healthy Housing works on advocating for those funding levels to be as high as they possibly can be, so that all of the work around the country can be done by people like you. So I am, the big L, a lobbyist, but remember, I like to think of it as lobbying in the public interest. So being a lobbyist just means you're asking members of Congress to do something that you think is the right thing to do for people that you represent. Everybody can be a form of a lobbyist. It is not a bad word. As a matter of fact, any nonprofit entity can spend at least 10% of its time asking a member of Congress specifically to do something. 99% of the time you spend talking to a member of Congress, however, you're actually doing education. That's not lobbying. If you're not asking vote for SB 50, you're not lobbying. You're saying, let me tell you about how lead is in homes and how it's affecting children and how these funds are being used. That is all education, and anybody, government employee, there is no restriction on that form of education in any way. The National Center for Healthy Housing does Hill Days annually. Sometimes we do them virtually, sometimes we do them in person. If anyone would like to be involved in that, we would love to have you join us. We also run a coalition, the National Safe and Healthy Housing Coalition, which has over 650 members. And if you'd like to join that coalition, the information about it is on our website. On the back side of the sheet that tells you about the National Center is fact sheets we do for all 50 states, as well as Guam, Puerto Rico, etc., for each state to have an understanding about what different agencies provide funding and whether your state is accessing them for every program that's going to help the healthy housing writ large. We also run a listserv called LeadNet, which if you are on the technical side, you might have interest in being on. Lots of really wonky conversations, but I know more about like lead in turmeric than I ever thought I would because of the lead down. I'm not, reading my label at home. So, it is very important that everybody who has something that they'd like to see change talks to their member of Congress. And it might start at your local level, at your city council. I know you all do great state work. As a matter of fact, the state work that you all have done so far has been turned into a piece of legislation that Senator Fetterman has introduced around whole home repair, which is what Darren was mentioning specifically, the idea that you go into that house, you want to do lead remediation, but the roof isn't on. Well, that's not a good use of dollars to put it into just the lead remediation without doing the rest of the work. So these programs and these ideas that you have tried and work on the ground need to have the energy of someone who can tell their story to be filtered up. And so when we ask you to do a Hill Day, reach out to your member of Congress, have some kind of advocacy as a group, it's because you all tell the best stories. I can go in and explain the line item B of this particular legislation, but without a story explaining what the constituents back home are experiencing from that, there's not a lot of incentive for them to listen to me. I'm only the voice for the people who are actually doing the work. So does anyone have any questions about federal advocacy or state level advocacy? I'm happy to answer questions. I think my job's been on TV a lot, so it's not not as mysterious or as interesting as the stuff that Nat does. Go ahead.
So I actually work in advocacy as an advocate, not a lobbyist.
Uh-huh.
But I wonder if you have any tips on how to keep the ear of people without getting on their nerves.
That is a good question, because it is a delicate balance. I would say when you're getting to know, and one of the things that people are predisposed to think is, I need to talk to my member of Congress. Your member of Congress is very important. However, the 10 people who work in the office for the member are the people who know all the information and tell the member what's going on. So don't be offended if you're having this meeting with someone who's 21. That's absolutely the person who writes up the brief and tells the Congress member what to do. So what you want to do when you first have that outreach is find a point of contact with that staff person and figure out what it is they need. Is there some fact that if they could find this out, their boss would think they're doing a great job? Is there an opportunity you can provide? Every boss wants to be in a photo op. Every boss wants to come to a site visit. They want to be out there with the hard hat. Find things that are like, you know, for a trained seal, what is the little piece of fish you can give a trained seal so that they say, I'm going to do the trick for you. And so you just got to keep on feeding the little fish until you get the trick. Further back?
Yeah, I wanted to ask about a policy related to RRP.
Mm-hmm.
So we heard a lot in several other sessions that the federal law, which requires all contractors that do any work in lead homes of any substance, be certified under
I am lead certified.
and how because the states do not in any way enforce that, we just don't have the workforce. So I know that there are some jurisdictions around the country that actually have interesting ways of enforcing that. And I know that the National Center for Healthy Housing has a really good section of their website of all the different kinds of state policies, but this one is absent. And I'm just wondering if I could suggest that maybe we include that, because I think it could be helpful certainly would be helpful to us in Pennsylvania, but it might be helpful to other jurisdictions too.
Yes, because definitely some states have decided to address it like, we're going to do this ourselves. You know, we're just going to jump in because clearly what the market's not working. And that has been a challenge for a while now. So I will take that back and have the people who write expert things for the website work on a section on that. We have a great scientist, Dave Jacobs, who I'm sure could give you a 20-page essay on it in 15 minutes. So I'll take that feedback back. Yep.
Sorry.
No, that's okay.
I'm sneaking in. My question is, so given the current state federally of things, and particularly with funding of programs, and your magic, ball, as you can see everything happening. But so what do you think is, should we continue to expect significant decreases in funding, or what are you guys trying to do?
Right, yeah. What is our strategy right now? Hopefully this doesn't get too weedy for people. Because we have seen, first of all, the president's budget, and the president's budget is usually just kind of an indication of what he wants. So that came out, obviously very destructive. Then the House put up their appropriations bills, pretty hard on our programs. But the Senate version is pretty close to level funding on most of everything. And at this point, we think level funding is a win. It's obviously a cut because inflation exists, but compared to many other programs, our programs have fared fairly well. If you look at the Office of Lead Hazard Control and Healthy Homes, like it's pretty much a level base. So we are continuing to work with our advocates. I would have to say the tiny bit of good news, if you can have good news in kind of a crazy world, is that there aren't a lot of pro-lead advocates. A lot of these people are fighting like, Big Oil wants to talk about solar panels. Well, there's no one who's like, let's have more lead. Let's get more lead. And so it's helpful to not have somebody working that hard against you. But, and it is a very successful program. I think one of the things that we should do as a community and try to do the best we can is continue to tell stories, give positive feedback, send things to your member about funding that you got through that program, and here's the great outcome that it had. They love to tell stories. They want to talk about their constituents. They want to go down and make a floor speech with a big old poster that shows, a smiling child whose house is lead-free. So the more that you can give back information that makes it clear why that program is valuable, it's a lot easier when you don't actually have an active opponent, which we don't at this point. Like, once again, who's pro-radon? No one's out here like, yeah, let's get more radon. So, but it doesn't mean that at the same time, they're going to say, is this program really working? Where's the proof? And so the more proof you provide will strengthen the chance that you'll get your dollars. And other than that, the budget's a mess, but it'll end up being negotiated into, an omnibus, which means they throw everything together, and the Senate numbers typically win. So I'm not up nights yet. Other questions? Look, I don't even need my whole 10 minutes. If anyone asks me a question on the side, feel free to.
Thank you, Darcy. Next up, we have Leah Schermeyer.
Leah.
Leah. Sorry. She is a health promotion specialist with Penn Medicine Lancaster General Health and has over 8 years of experience as a professional in the public health field, working on a variety of projects in the field of environmental health, child and maternal health, mental health, substance use, and beyond. She specializes in health and housing policy, research, community partnership, marketing, and program coordination. She also currently fills the roles of co-chair of the PA-led Free Promise Project's Public Engagement Committee, as well as Lancaster County Healthy Mothers, Healthy Babies Coalition.
That makes me sound very interesting. Let's see if that rings true. So I'm going to hand out some flyers. I'm just going to send them around. It's just an outline of what I'm going to talk about. And then if you haven't seen, there is binders that were on our tables that have our outreach materials. I'm just going to send them around. If you haven't looked at them and you want to, just take a look at kind of the spread of materials that we have that I made. So like Nat, I could probably talk all day, so I'm going to set myself a timer too, so I don't talk everybody's ear off. So first I'll say that a lot of the things that Nat shared about the city's work is very similar to our program. Her role kind of lives in the mix of mine and of Mandy's, who is our also a health promotion specialist that works more directly with families. So my role is really more kind of upstream. So I'm not really working with the family every day. I'm out in the community, I'm doing policy work, and things like that. So I'm going to talk about kind of 3 different main points: building community, developing education and promotion materials, and then policy stuff. So building a community, and over the past 4 years, this program launched in 2021 through Penn Medicine. I've had to build the community that surrounds this program from the ground up, because I am now the sole person that has survived since the start of this program. Many people have gone on to other really great roles. No one left in tears. Everyone just had bigger plans in different fields. So I've learned a lot of different things that I think are going to be valuable tools if you're thinking about how to build a community around the work you do, whether you already have a lead program in your city or community, or you're just a person that works with families. So the first thing when you're building a community is you have to think about who are the advocates and the allies in your community. Who is going to be someone that is interested in the work you do? So for lead, it's pretty broad, right? So you have families and parents and sometimes grandparents, because we know that there are multi-generational households in every community. But we also have people who work in the education field. So, and that's every range. You know, school age, pre-K, you know, and also the people who work in administration, because they see the downstream cost of lead poisoning in their school district with special education. And then you have medical providers, obviously. They see the medical. But also other things you might not think about are people who work in juvenile justice, because often those are downstream impacts. So there's all these different people that you can think about as allies in your community, and then think about, okay, how can I connect with them? How can I find common ground with them to show them that this work is important? And oftentimes, because they already are, you know, involved with the population you're working with, they're going to be like, oh yeah, that makes sense. And that's where that education awareness comes into play, because you'll meet a lot of people who maybe don't know that lead's still a thing. And I hear that, I don't know, probably once a week when I'm out in the community, and they go, so is lead poisoning still like a big deal? And I'm like, yeah, unfortunately. Unfortunately, but I think that that education and awareness is so important in every community, because there's probably a lot of engaged allies that just don't realize that this is such a big issue still. So the other piece I want to talk about is attending events with impact. So this is a really interesting statement. So, you know, as you are maybe building a community, you might get invited to attend an event. And when I think about attending an event, there's different things I think about, like who are they targeting this event to? what community is this event in? Because sometimes I might go to an event that, you know, maybe it isn't exactly meant for us, but maybe that community is really important to outreach in because they don't have a lot of events, or they're kind of wishy-washy about whether they're interested in this stuff. So thinking about all those pieces, just not, oh, well, it's not an event targeted for families with little kids, so I don't need to go to that. Think about those things. The last thing I'll say is, and this is something I carry through my work, is that there's a true meaning behind what partnership is, and it's not just you show up and you present and you leave. That is not a partner. If you gave them great information, but especially in a lot of communities where they're maybe more insular, and maybe they have a lot of, you know, oh, in this school district, or oh, in this municipality, we kind of are wrapped around our families. If you drop in and you drop out, you're out of their mind in a month. So keep showing up. I think that is so important when you're building a community. You need to keep showing up. Even if whatever you're talking about, lead, healthy home stuff, is not the most important thing that month or that quarter or that year, because we all know that there's a lot of other things that are going on right now where we're talking about food insecurity or housing concerns with, you know, rent or, you know, any other thing you can think of. But just keep showing up, because your partners will see that you care and that you care about the things they care about, even if they're not your thing. Okay. So as those binders go around, you'll see the kind of breadth of education materials that we have for both our Healthy Homes and our lead program. So if you notice, there's a really recognizable brand in those things. They have a really cohesive color scheme. They have similar wording and branding. That's important. So if you're starting a program and you're like, wow, I think we need more educational materials, think about those things, because it makes your services recognizable, ties them back to you, ties them back to, oh, this is coming from, I don't know, the city of Harrisburg, or this is coming from Ledford Families, or the city of Lancaster. The branding, I know it sounds silly, because, you know, I don't know if anyone is a marketing person in this room, but it matters, because it ties the work back to you. And then when they have a question, or they're like, well, how can I get help? They know intrinsically, because your materials are so cohesive and they're pretty. So when I think about developing materials, if you're thinking about those types of things for your program, don't reinvent the wheel. We all work in lead, or most of us do. So a lot of us might have already made materials, or there might be another really great institution that's already made materials on the topic you're interested in. Take those things and use them. They were made to be shared and educated with families. So like, if you don't need to make the material, don't spend the manpower, make the materials that aren't there, or focus on translation, like what Nat was talking about. I think the other thing I'll talk about with educational materials is that you should cater your language to an appropriate reading level. So we have the benefit in the health system of having a really robust health literacy initiative. We have a whole department that does health literacy. So if I develop a flyer and I send it to them, they'll tell me whether the language is appropriate, and if it's not, they'll fix it. Not everybody has that, but those are things to think about. When you're developing material, think about, if I handed this to a 5th grader, would they understand what it says? If they don't, unfortunately, a lot of people across Pennsylvania and the US might not either, because the literacy level nationally, they really want everything to be at about a 4th or 5th grade reading level max, because we want everybody to understand. We want everybody to get the message and understand the education, and not be looking up words and trying to understand niche vocabulary. And I won't touch on it too much because Matt talked about it a lot, but translation is so important. Lancaster particularly, we have a huge refugee population. We deal with families that speak every language under the sun. I feel like every month there's a new family, and it's a language I've never heard of. So, like, we had a family that spoke a language that was so niche that we had to employ a translator outside of the hospital, and he was the only translator in the county that spoke that language. So, meet the families, know that there are families probably in every community that speak a language other than English and Spanish, and they may need your services too, but if they can't read your materials, they're not going to end up getting it to you, because like Nat said, they're less likely to reach out. So with my last 2 minutes or so, I'm going to talk about policy stuff. So, lead-free families has 5 different pillars, and the last pillar is policy. Because, of course, doing work on homes and fixing homes is a really visible, impactful change. But having policy that outlasts this program, no matter how many years it's funded, even if we get another 10 years after this 10 years expires, policy can really exist in a community and fix a community in a long-term sense. So our focus is lead ordinances, and some of us work in communities that have them, some of us work in communities that we wish had them. But across Lancaster, we have 3 right now. So the city of Lancaster has a really robust lead ordinance, and they also have a city health bureau that helps support that. But we also have 2 other communities in Lancaster County that hold a lead ordinance, and that is Manheim Borough and Columbia Borough. And both of those lead ordinances were enacted with the support of our program. So we had meetings, we did presentations, we had landlord forums. Darren and other people on our team went to borough council meetings. It's a process, because you may have key players that are really interested and other key players that are really not interested in the same community. So it's kind of, yeah, he says Manheim. So Manheim's a great example. So Manheim, the borough manager was very passionately interested in having a lead ordinance. And when he put it for a vote, they drove right down the middle, and the mayor had to cast the deciding vote for the lead ordinance, and he did vote for the lead ordinance, which is great. Then 1 year later, they they replaced a couple of people on the council with elections and things like that, and the first thing that council did was try to overturn that ordinance. And the mayor stepped in again, and he vetoed that overturn, which is not something that mayors often do. They often tend to stay out of those types of politics because it's the will of the council. But he was like, no. Because I actually had a conversation with him. He had the very distinct and correct impression that multiple individuals on that council were doing it for personal gain, because they were like, it's costing me money because I'm a landlord. And he's like, I'm not okay with that. You're not making decisions based on your personal business in the council. So those types of things are challenging, and we're continuing to work across the county to help other communities that have the capacity for an ordinance to think about whether that's something that they can look at. And if they don't have the capacity for an ordinance, because Lancaster has a lot of really small communities. They don't have a rental registry, they don't have a codes officer, so they can't have an ordinance, but how can they help in other ways? We have other municipalities who maybe don't have the capacity right now, but we can let them know, hey, we have a lead poisoning case in your community, and the landlord will not comply. And then they will make an executive decision separately to send a letter, make a call to that property manager to let them know that the borough is in support of them going through our program. And it works, even if there's really no teeth behind it because there's no ordinance. So I think those are important conversations to have too, if you work in a municipality that doesn't have the ability to have an ordinance. There are other pieces.
I wanted to add to what you were saying about using the property maintenance code for other municipalities, or doing that with situations that we have in lead poisoning.
Yeah, so chipping and peeling paint is in that universal property maintenance code. So oftentimes that is an easy tool, because usually the chipping and peeling paint is not just on the inside of the house. Usually it's on the beautiful eyesore of an exterior. And a lot of times municipalities will be like, yeah, that, like we had one in a municipality in our county, and that was a big part of their citation because it was bad on the exterior. And he was like, they just like, regardless of what's on the inside, he's like, that's just chipping and peeling on the outside is something we can cite on. So things to think about. So with that, my cards are up here. My card is also on the table. If you're interested in getting those materials, or you have ideas for materials and you want a person to bounce ideas off of or support on those types of things, always happy to have those conversations. And I do policy work through the Lead-Free Promise Project as well, and I'm also happy to connect about those things if you think I might be helpful.
Yeah, just a comment. I heard several times today about, you talked about how the lead affects, has direct effect on students with special ed. But we don't want to also overlook the fact that it affects students who are not in special ed, but have cognitive losses and may have not been diagnosed. It affects them, especially black and brown children. It affects a lot of them in standardized testing. And that's a big issue for a lot of districts that we sometimes overlook. We just say, oh, it's from where they came from or where they live. But no, it has a lot to do with what they ingested.
Yeah, absolutely. I think that there was a question in the other panel about our connection with IU13 or special education services and early intervention services, and we have a really direct tie to them. They refer families directly to us. Mandy refers families directly to them, and IU13 also has on occasion come to us with families, usually with older kids who have some really severe things going on, and often maybe accompanied by pica, and so they might be lead poisoning their shelf at the age of 9. And then we explore, like, what does that look like? Like, we have funding right now through ARPA to help families that have children with households that have children over the age of 6 that are lead poisoned. And right now I want to say, Mandy, correct me if I'm wrong, we have 5 active families that we've done that through. Yeah. So it's a need, and we're trying to fill it the best we can, because you're right, it affects older kids and it affects school funding then, because testing scores affect school funding.
When you talk about like saving resources and not recreating the wheel, one thing that I learned the hard way with translation materials is for some of those like unique dialects or lesser known languages, when we had materials translated, we found out that there are very low literacy rates in some of those countries. So it's very common that translating might not do any good, and it's better to just have an interpreter work with the information. So that's just something to consider when you're thinking of getting something translated.
Yeah, that's absolutely something we've interacted with. We've had refugee households where particularly the women, the adult women in the household can't read.
But your graphics that were on the pages were really helpful because they were, while they were like cartoony, they were realistic.
Yes.
And cohesive, and that's something that our organization uses when we do things for people who can't read or don't read, is using pictures a lot too to help drive information home.
Yes, so that's definitely a health literacy tenet that I agree with. If you can use a picture, use a picture. What I'll say about our program is that, so Mandy goes out to homes, and a lot of these materials come with her, and she either has an in-person interpreter for as many languages as available, or she uses a video interpreter, or our lowest rung is a phone interpreter, but there's always an interpreter. So we try to translate as much as possible, but we also recognize kind of what she shared, that sometimes the literacy level isn't there, and Nat alluded to this, sometimes the lead as a thing is not there, that they may come from a place where they don't have a word for that. They don't interact with that, because in some places, housing's built a lot different in other places. So oftentimes lead isn't coming from their home. It's coming from the water. It's coming from pottery or spices. So like, there may be places that refugees are coming from in our community where they don't even know what lead is. Like, I know for a fact we've had translators say that there's not a word for that.
Swahili.
Yeah, so they have to describe it.
For lead in Swahili.
Yeah.
It's toxic metal. It's how they have to translate it.
Yeah.
Thank you. We have 5 minutes left. So I was wondering if I could get all 3 panelists up here, because I have a question for all 3 of you. and then we'll wrap this up, if that's okay. All right. So I'm like I said, I'm the Deputy Director for Policy at Children First. We are an advocacy organization. And it's very true that if you can build a critical mass of people asking for something, you're more likely to get it, right? However, families who are affected by lead poisoning are hard to identify in the advocacy process, as our Director of Parent Empowerment can tell us here. So what we would love is to be able to find families who are willing to speak out about the impact of lead on their homes and their children, but it's hard to find them. So how do we build those stories so that we can get more lawmakers interested in this issue? Who wants to start? What do you think?
Well, I know that the National Center for Healthy Housing did a project like that about 7 years ago when we were having a Hill Day, and one of the tools that we chose to use was for families that we had been put in touch with. We were doing a lot of work with Flint families, et cetera. We brought our communications person to the conversation to literally get on the phone, have a call, ask the family to tell them their story, and then he was able to write it, because I think it can feel overwhelming to think that they have to put it all down on paper. And if you say, would you please just tell your story and we will help you make it sound like what you think you're saying, and then add photos, etc. And the nice thing is when we had those, then they're kind of evergreen stories, but it was providing the support so that we are literally taking the words down for them, increase the likelihood that they would participate.
So first, I'll echo what you said, Mai. It is hard to identify families that want to talk. Even when they're going through programs like the City or our program and they have a great experience, they might be like, well, I don't like public speaking. I don't want to be on a camera, things like that. So like the video you guys saw over lunch, that was a family we identified that went through our program that was interested in doing that. But it was a process. We had several families that we considered, and usually our family advocate, Mandy, is kind of the one that identifies those families that she feels like might be interested, and then we kind of go through the process of talking to them. Luckily, a large health system, we have a whole PR department, which is, there's detriments and benefits to that, because, then there's a lot of red tape and a lot of the, things they have to sign and all those kind of good stuff. But it also does help because they really understand like that process intimately, and you don't have to understand it as the program that's just providing the family. But it's hard, and like we're still navigating how that might look for us as we continue to like develop, videos or testimonials in the future. You saw some, if you look through the binder, there's some testimonials for families that were like positive things about our program. Those are collected in our surveys, and we also find that beneficial, just asking like for like open-ended positive feedback, and maybe 50% of the time they leave it blank, and that's okay, because we all know sometimes we just don't feel like writing anything. But sometimes we get really nice reviews that we can share on social media or put in other materials. So I think 2 surveys and just asking for open-ended positive feedback. So maybe then you can think about, because oftentimes that positive feedback may allude to who the family is. If you're doing an anonymous survey, oftentimes you don't want to do it anonymously, because if they tell you they have a really bad contractor, you probably want to know who it is. But those are types of things too where you can go, oh wow, the Smith family really left a really great review 2 months ago. Maybe I should link back with them. So maybe surveys.
And I do want to add that something that really does help throughout the whole process, and I imagine would help with finding families who are willing to speak out and share their experiences, is having openness. I try to be really, really open about everything when I meet with that family initially. I talk about relocation at that first meeting because I don't want to blindside them with it when they're already knee-deep in the process. We have actually collaborated with some researchers before. I don't know if Dr. Okach is here. But even there, we ask families if they're willing to share about their relocation process and take part in this kind of interview. And there are families who have been willing. That is anonymous, but again, that open two-way communication. And I encourage them, like, we want to hear about the stuff that was hard. We want to hear about the difficulties you encountered, because we want to learn what we can do to make this easier. And from those conversations, we've made like a packing list for relocation that we hand out of things to bring. We've made a list of what's going to be, needs to be done before the contractors come in, and things that the contractors won't do, like hanging up curtains when they come back or rolling your rug back out, just things that help them to be mentally prepared. So I think that openness would probably go a long way in helping to find people who would participate in those kinds of things.
Can I add a comment to that? Hi, everybody. I'm Amy Covetta. I'm the comms director for Children First. We're a partner of the Lead-Free Proms Project. If you have stories, you don't have to clean them up. You can just send them to the folks that work, not for me. I have enough work to do already. There are comms people on the Lead-Free Proms Project, and they will take whatever story you have. We can keep people anonymous. We could videotape people that their face doesn't show. like there's so many different ways that we can tell a story without somebody having to write it out. You could be meeting with somebody and just record, like I'll put on my video camera and just put it down on the table and it'll just do the audio, and then people will send that to me and I'll pull like a nugget or two. So it doesn't have to be them writing out what their narrative is. We can do the shortcuts in order to get their stories out. So Lead-Free Promise Project or me, Amy Cobetta, Children First. Thank you.
Thank you so much to our speakers.
So Joyce in the middle here, Joyce Rubinskis, has been a dedicated healthcare professional for 45 years. She has served as program manager for UPMC's lead poisoning prevention and education program in central Pennsylvania for 20 years. A licensed lead risk assessor and health home specialist in Pennsylvania, Joyce has extensive experience in lead poisoning prevention and environmental health. Passionate about achieving equity in lead testing, Joyce is an advocate with the Lead-Free Promise Project, striving to ensure that all Pennsylvania children, not just those covered by medical assistance and CHIP, are tested for lead toxicity. And then next to me here is my boss. Elizabeth Ibner is manager of community health and wellness at Penn Medicine Lancaster General Health, with more than a decade of experience leading complex public health initiatives and research studies. Elizabeth has authored numerous peer-reviewed publications and presented at regional and national forums. In her current role, she directs the Lead-Free Families Initiative, which works to eliminate childhood lead exposure and reduce elevated blood lead levels in Lancaster County. And then furthest from me is Stephanie Voigt, Director of System Community Health at WellSpan. Is that correct? Okay, there we go. Stephanie's role at WellSpan includes responsibilities for WellSpan's Community Health Needs Assessment, Community Health Improvement Plan, Community Benefit Report, and oversight of community grants and health coalitions as she collaborates to address emergent needs in Pennsylvania. I'm wondering, do you work in the community at all? A little bit. Stephanie's role includes focused attention on health equity, life expectancy, and the impact modeling. So, each of these presenters have a short presentation for us, and then we'll have questions at the end. So, we'll start with Joyce.
Come on. So just the point is that you can, yeah, and you can just float it through. Right, that one? Okay. Yeah. All right. Thank you, everybody, for staying to attend this. This is a very great opportunity we have to share information among ourselves. I am Joyce Urbanskis. I have been the program manager for the PMC, used to be Pinnacle, this year. Yep. Just so we can hear you. That better? Perfect. Okay. And used to be Pinnacle, for UPMC now, and been in this position for 20 years. I started in my hometown up near Scranton, where I still live north of Scranton, but do come down to Harrisburg on a regular basis, back and forth. That's how devoted and want this program to continue working. Although sometimes I feel like a traitor because I'll get a phone call and I'll say, hey, I'm from Dixon City. You don't know where that is, but my child is lead poisoned and there's nobody up here to help. And I feel terrible. I really do. And I say, I do know where Dixon City is. Give me your address and I will work it in somehow if I can at least just walk through your house, let you know, do some dust wipes or whatever. But no child, no parent has ever turned down, and it should never be turned down. You don't want to think that that child grew up and because of you didn't want to go outside your area, that child now has a developmental or physical delay. So I do what I can. Up here it does say Jolene Scott is my lead risk assessor. She has moved on to the Pennsylvania Department of Health in the lead. And right now I have Kevin Kaufman. Some of you do know him. He's excellent and he is a lead risk assessor and he does 99% of the cases that we do receive, okay? We used to be the childhood Lead in Healthy Homes program from 2013 to 2016. And that was a great program, and it was a grant from the state. And it was so great that I guess they ran out of money, so they did not renew it. And in 2016, then the state announced that they were going to get out of the lead business for now, as far as grants go. And I approached the president of UPMC and said, just because there's no program at the state doesn't mean these kids are disappearing. As a matter of fact, it's going to multiply because it's a revolving door. And we need to take care of these kids because nobody really else is. And he agreed. So he said, but just so you know, you're running a business now. I said, okay, whatever it takes, I'll do it. So we did, and since 2016, we have been running the program, and our funding comes through medical assistance, basically mostly medical assistance payments for medical assistance children that are referred to us from the physician's office. We do have some grant money. As many of you had heard, the ARPA funds. We do have that for people who are not insured or they have private insurance and cannot afford a lead risk assessment of their house. We serve 15 counties, South Central PA. Yes, there is just 2 of us, and we are spread pretty thin. We try and geographically do it. If we've got one in Huntington, we'll try and get somebody else out that area. Same thing as if we're going to York, we just try and get as many as we can in. Our referrals are coming in really fast, especially now. I was just telling somebody, usually July, August, September, we get a lot of referrals because school has started, kids have got back to the doctors or going to the doctors, going to preschool, whatever, so they're being tested. And then we see a lull usually around October, November, December. We don't see that lull. It's a good thing and a bad thing, though. Good thing that they're being tested and coming to us. Bad thing that they have lead poisoning, but at least we can do something, and it's better to know about it than go on in life and not know about it. So we're trying to help reduce the lead, one child at a time, one house at a time. This is our referral form that we use. Most of you would be familiar with it. And it is on our website. And if you go to UPMC.com, community and lead, then you will find that. There's a fax number on the bottom of it, and that would be sent in. All that in yellow does need to be filled out. Once I receive a referral from the physician, I will think about what am I going to do here. So let's do a couple things here. What's the age of the home? Any neighborhood hazards? Is there any buildings around there? Was there a battery factory? Was there a motor vehicle or mechanic shop? Anything that could possibly lead to being lead. The size of the home. Is it rented? Is it owned? Who's the landlord? We need the name. And was there any lead inspections done prior to this phone call? So once we get that, we make a phone call and we're going to ask the parent. Best question I've ever gotten, the best question I've ever asked was, where do you think the lead is coming from? 9 times out of 10, they have an idea. They say, you know, I was thinking about, my husband and I were thinking about this, and the baby's room, the crib is right next to the windowsill. Or we have an air conditioner, and the air conditioner, under that is the playpen where we keep all his toys. So generally, they have a pretty good idea. So we will go with that, but we test every painted surface in the house that the child has access to. We also do soil, and we do water. Any paint chips that we need to do, we'll send them in too. We'll ask them, is there peeling and chipping paint? Where else does the child go? Because some of them say, you know, nowhere. These kids never go anywhere too when you ask them, but they'll say, you know, grandma's house? Yeah, sometimes. Well, how old is grandma's house? Oh God, old. So sometimes it's not their house, but it might be babysitter, it could be a daycare. We will go wherever that child goes and we will test with the XRF and our dust wipes, and we will find it. We try not to ever stop until we find it. You know, it's a challenge. I feel like a CSI sometimes with the dust wipes, but we really want to know. We check for bare soil. Are they playing there? Let's check the soil. We use an XRF, dust wipes, which is our tools when we go out. Of course, we have containers for the soil, and we have two bottles for any water that needs to be collected. We use the XRF, which is a lightweight, very valuable tool. It tells you everything. You plug in what wall, where is it located, is it painted, or is it paneling? So once we get that report, it'll just spell out everything. So after calibrating our XRF, we test all painted, varnished, and tiled surfaces. We also test bathtubs, because bathtubs, especially the older ones with the club, notorious for having lead. And we're mostly concerned if they have any chipping, peeling. But around where the water in the faucet goes down into is often corroded. And then if we were to do a dust wipe around that, we will find that that is high in lead. So that's a big one that we find as far as bathtubs go. Stairways, antiques, repurposed wood, and old toys. Repurposed wood was like, I was doing a presentation one time and I was going through all this and I felt like I was putting them to sleep until I said the repurposed wood that people make, get old farm wood and they make some frames out of it or whatever. And they said, wait, what? And I said, yeah. And they said, what has lead? I said, yeah, for using an old farm. Yeah, farms are notorious that they were painted. So that was something that got their attention, which was good. I knew they were awake. So we test inside and outside. Porches are notorious as well. We really test friction surfaces. And friction surfaces, as many of you know, the windows have friction surfaces, the doors, the stairs, the flooring, okay? So the average home will have between 150 and 225 or more. Especially if you're Kevin, we'll have a lot more readings than that. Kevin tests everything, which is good. And we do obtain soil for lead. The first 2 inches, first 1.5 inches to 2 inches is what you want. And water, we do check, especially if there's a well. And a lot of schools had a problem in the past with lead pipes, and they had it closed down a lot, so they got the water fountains changed in the piping. Once you get the report, right now when we go, everybody will know in the house, they're following us around, and the machine will tell us right away if it's positive or negative, so they do know that. But I tell them, you're gonna get a written report in about a week to 10 days, but we have to send out the labs, so that's gonna take at least 5 days. So it will tell you the reading, the result, the room structure, member, the substrate, which wall, what was the condition. Of course, we're worried about things start chipping, peeling, or a friction surface, but it's really good to know if it is lead, because if it breaks down later on, you're moving furniture, bump the wall, create some lead dust, it's good to go back to that report and say, hey, yeah, that was lead, we better be careful. Once we download it back at the office, we have a detailed report and we have a positive readings report. We send them out. Letters are sent with the report to the PCP, the parent, codes, landlord, state health nurse, and the medical assistants, MCO. Lead dust wipes, so important, but so often not done. And if you're going to have some remediation done or abatement done at that house, they are disturbing. So you really have to have a contractor or a person who is licensed to go out and do those lead dust wipes. Because when you think about it, there could be more lead dust there now than there originally was because of things being moved around there. So I am a big advocate for the clearances on that. Okay. Thank you.
I'm going to talk more about our lead-free families program, specifically through the lens of how we got started, how we set it up, And I'm really, really here to share with you what we've done so that you can take it back to your communities, the spaces that you're in, to be able to replicate anything, learn from what we've done, learn from our mistakes. And I'm also happy to answer any questions that you have after this as well. Okay, so first, because I have a public health background, naturally this is coming from a public health lens. And so I wanted to sort of talk through our program in terms of assessment, planning, implementation, and then evaluation. And so that's sort of what's going to guide our presentation. And so to start at a big picture, high level, I wanted to show a map of the United States to just kind of help us see where Pennsylvania fits in the scope of the nation as it comes to old housing stock. So this shows at a high level homes that were built before 1940, giving you an idea of where Pennsylvania sits. So the darker colors are a higher percent of older housing. And according to the 2022 American Community Survey estimate, Pennsylvania ranks 5th in the nation for the percentage of housing units identified as having been built before 1950 when lead paint was most prevalent. So we know 1978 is when it was banned, but there's a ton of old housing stock in Pennsylvania and we're ranked 5th there. So this map was shown earlier, and this was a really important map to help sort of set the landscape for the work that we're doing today. Without data and the research that took place to develop this map, we really wouldn't be here, and I wouldn't be here talking about the Lead-Free Families program. So it's been, I think the data aspect is incredibly important for setting the stage for painting what is the issue of lead in my community. So this is showing the percentage of residential structures constructed before 1978. So in the middle, you'll find a lot of darker colors. That's where Lancaster City is located. There's just a lot of older housing stock there. And then there's other areas kind of throughout the county as well. And you can see even in like some of the areas with the orange, those are really our rural areas and they have a good amount of older housing stock. And then this map shows the amount of elevated lead levels in those areas. So again, in the middle, you'll see the darker colors are more significant, and that's our city location. Kind of up on the right is a zoom in of our city as well. So we can see kind of closer up what the lead EVLL percentages are for each of the areas. So this data, again, was like super helpful in us being able to paint the picture of the issue of lead in our community, and that it's, at the time it was like 2020, and this was still a big issue, even though 1978 lead was banned in residential lead paint, and we're still, seeing this issue. Another issue that goes along with this is the screening rates of lead poisoning. So we have a pretty low percentage of children that are tested in our population, so it's 22%. The Pennsylvania total is 19%, but we are still pretty low there, and so that's something that we have been aware of and really sort of was built into the design of our program, and something that I'll talk about a little bit later what we're doing about that. Okay, so moving on to the planning aspect. So this is Public Health 3.0 is a framework that really focuses on the evolution of how public health has worked in the nation, and essentially now it's really focused on partnerships and working collectively through different organizations to be able to make an impact. We talked about that a lot this morning about how the benefit of working together and being able to collaborate to be able to improve lead poisoning in our community, and really kind of focusing on those social determinants of health, or the ways that lead is able to improve social determinants of health and health disparities within a community. And so now more than ever, really designing a program that crosses multiple sectors, including healthcare, community organizations, local city government, and individuals is really important for public health initiatives, and should be taken into account when you're developing and implementing a lead prevention program. And identifying key stakeholders, key partners, and advocates have been really helpful for us.
And some of these include the City of Lancaster, Green and Healthy Homes Initiative, Lancaster Lead Coalition, Union Community Care, other healthcare organizations, and social service hubs within our community. And also I'll mention the Thrive to 5 program that have been really beneficial in being able to advance our work. So a key piece of being able to do this work is getting stakeholder buy-in, and so we did this through kind of each of these means that I have listed. So framing the issue, we described the local impact of not doing the work. We shared the downstream effects that lead poisoning has on a community, including crime rates, educational attainment. There's so much research that talks about those downstream effects, and so educating our stakeholders, our funders, our community about that has been beneficial. And aligning with funder missions. Aligning with priorities, so in our health system, we have a community health department, and really impacting the well-being of our community has always been important for us. We have our roots in being a community hospital, and so as a part of that, we've been doing that for years and years, and our leadership is very supportive of that. And so this program naturally sort of aligned with those priorities. Making the case as well is important, kind of outlining the return on investment, the long-term savings across the sectors, and how lead poisoning prevention really can make an impact in so many sectors. We've also talked about building trust and kind of calling folks to action, and both of those are incredibly important in engaging stakeholders. So how did we get here? So we do a community health needs assessment every 3 years as a part of being a nonprofit hospital. So we started to identify lead being an issue through the Lead Coalition and also through our community health needs assessment, and thinking about quality housing is so important for someone's health and well-being. And so in 2020, we proposed as a community health department to our board of trustees at Lancaster General a proposal for an incredibly comprehensive lead poisoning prevention program. We were approved and received $50 million over a 10-year time period to focus on lead remediation, among a number of other items, to really be able to make an impact in our community. And 2022 data, we are also seeing a need for continued work in lead remediation and healthy homes. So our initiative is really a five component, multifaceted public health intervention where we're kind of tackling the issue from all sorts of areas. So I'm going to talk through each of these. So it launched in August of 2021, and education awareness, you'll see that one first. So that's really our goal, is to increase awareness. I talked about that a little bit this morning, but really providing county-wide information and education about lead poisoning to residents, community agencies, and at community outreach events. We also are able to provide education to providers and join provider meetings to share with them more about lead testing, the importance of lead testing, and go into some of the nuances about the 3.5 level, and I can answer questions about that. But that's been helpful for us to be able to continue to advocate to providers to encourage them to place a referral to our program and have kids screened. For screening, we're working with primary care physicians, not only within our organization, but throughout the county, to increase lead screening for all children under the age of 6. So even though our program is funded by Penn Medicine, LGH, we are not limited to serving just our patients. We actually want to serve more patients than LGH, because our program it doesn't matter what provider you have. We truly want to be able to make that impact. Remediation, so this program is free to families who own or rent their home. There's eligibility requirements that kind of go along with that, but essentially if they have a child under the age of 6 or are pregnant, if they live in a home that was built before 1978, and if they meet the income guidelines, then they are eligible. And landlords and tenants, we can kind of work with both to be able to do the program. And Green and Healthy Homes Initiative, this is really where their work is focused, and they're helping us to be able to they work directly with the contractors who are able to do the work. And so that's been a really helpful model for us, because our team then really focuses on getting the referrals in, processing them, determining eligibility, and then we hand it off to the Green and Healthy Homes Initiative to kind of handle that piece. That's also allowed us to have a significant volume of homes that we remediate each year, which is just has helped us be pretty efficient. So that's been great. Our case management piece is an aspect that we're able to prioritize children with elevated blood lead levels and can assist with navigating resources for them and getting the remediation completed sooner than cases that we get where there's not an EVLL in the home. And we will continue to follow the child until their EVLL goes down. So that's another kind of unique aspect of the work that we're able to do. And then policy and advocacy is the last piece, and this is really working with our local municipalities. Again, we don't have a local municipal public health department, and so we're working with the local municipalities on their housing codes and standards to help them create safer housing in Lancaster. Okay, so then we move into implementation, and so thinking about who our audience is, how do we reach the folks that can benefit most from the work that we're doing? So focusing on children under 6, we know that they're most vulnerable, and pregnant individuals as well, and families that live in older housing. This is where the data comes back because we can look at the data and kind of know where this is. And then secondarily, we're working with landlords, healthcare providers, and a little bit with schools and childcares. But that was less of a need in our community. And then focusing on community education and outreach. Those referrals from healthcare providers are the single most important for us to be able to do remediation in homes in the community. And then we continue to also do community education, partner networks, and kind of all of those things. So our focus has really been to provide countywide information and education about this. We have it in all kinds of languages. We're at tabling events and really doing what we can to sort of get the word out there about the work and about the issue of lead in our community, and offer lead education and resources to families who don't qualify for our services. It's another unique part that we're able to do. So if someone calls in and they make too much, or they live in a different county, we will do what we can to really work with them to be able to give them a list of, here's some lead risk assessors that we trust, here's some contractors we can really kind of give them the resources so that they're provided with things that they need to be able to move forward and make their home lead safe. Case management, and then also the local municipality piece. So the integration with healthcare is significant for us because really physicians there's not a system in a normal healthcare setting for physicians to be able to give a medication, fix lead poisoning, right? There's not a medication that they can just give them and they can go on their way. And so Lead-Free Families has really been able to be the solution for our patients and any patients who are diagnosed with lead poisoning. And there's that whole support system that we're really able to kind of come alongside the family and support them in all the ways that we can to be able to improve the housing in there, improve the exposure, reduce the exposure, and improve the setting of the home. And then we're also able to have some goal setting around lead screening. So this is where that screening piece comes into play, and we're really working with leadership to increase screening, remind providers about that, and have that standard health maintenance prompt at 9 to 12 months and 2 years. We, for our community, because we do have such an old housing stock, it's recommended by the CDC that it's universal screening that's taking place. So that's something that we've really pushed to implement. And then engagement with our community and healthcare organization has been really important kind of throughout, and because LFF is, we've been here since 2021, we're doing the remediation, but we also can do so much more than that, and being able to partner and engage key stakeholders in this work that we're doing sort of on an ongoing basis. And be able to reduce that lead exposure. I hope the bottom of this is a little wonky, but you get the picture. So this slide I wanted to use as an example to really emphasize the importance of data collection. where you're able to. We basically track everything. We have a system, ETO is the name of the system that we use. We also, it connects with our electronic health record, where we're able to really track the impact of the work. And something that the data is a piece that I've been really focusing on. But that has allowed us to show a graphic like this that shows pre-post the decline of elevated blood lead levels among the individuals that we work with and the families that we work with. And so, hold on, let me grab this quick. We are, I'm going to show you the number. I can't find it. I'm just going to move on. But yeah, so it shows the decline of our EBLLs, and it's one that we're able to then report back to the stakeholders and report back to our funder to show them the impact of the work that they've put their money behind. Because again, stakeholders and folks that are providing the financial support, we want to make sure that they're seeing not only that we're doing what we said we would do, but that it's making an impact. And then I also wanted to mention that we started small in our program. So our first year, we remediated 65 units. Second year, 204 units. Third year, 231. Next year, 190. And then this year, we're at 51, on track to be able to do about 200. So we've remediated in total over 740 units since we started the program. And so we're really excited about that, and those volumes are great. So the client satisfaction is another piece that we really value. I talked about this earlier, so I won't go into too much detail, but we collect it and we track it and take a look at what can we do to make improvements to the program, make sure that the clients and the community is happy with the work that we're doing. A few lessons learned. So primary prevention is something that we want to focus on, but is not always everybody else's priority. So to be in our program, you don't have to have an elevated blood lead level, but you have to have your homes built before 1978 and there's lead in it. And so often there's less folks who are interested kind of from that perspective. We also have some marketing limitations, and I think just coming from like a public health standpoint, we're getting the word out there in the ways that we can do best. But if I had $1 million, I would also add a marketing budget that we could really get the word out more and use that for promoting our program, promoting awareness and education. So if you have any great ideas about how we can do that, let us know. And then also our partner networks have been really critical. We talked about our partners with the city and other healthcare organizations as well have been great. And follow-up is important, and that can be tricky with families sometimes, and just answering our phone calls and giving us a completed application, and we're trying to make it as easy as possible. We also need certain things, so that's always sort of a balance just on the day-to-day of how can we get what we need while we're also not having a lot of barriers for people to participate. And then also flexibility. I think we've learned a lot through the program, through the years that we've done this, and different audiences respond differently to how we approach outreach and communication, and so we're sort of always thinking about how we can improve that. And with that, I'll pass it to Stephanie.
Sometimes it's really hard to stay still. So I'm going to try to go through my slides really quickly to make sure that we have enough time for questions at the end. But I'm Stephanie Boyd, and I'm here with WellSpan. And I see a number of colleagues, so you guys throw your hands up if I miss something or misspeak as I go along here. I'm a little bit of a storyteller, so I'm going to start with the first slide as a little bit of a story. So I'm sitting in New York City. I'm meeting with the American Hospital Association. WellSpan's going for this big award. We're super excited about it. We're meeting with this gentleman. We start talking about lead. And he looks out at the neighborhood and he says, "We've been talking about lead for 50 years. Why are we still talking about lead?" And I thought, oh no, we just lost the award, right? And then he says, "No, you should be talking about lead, but it's ridiculous that we still are." And I agree, right? So I put this history up because I know I'm preaching to the choir here a little bit, but I put it up because we have literally been talking about lead for multiple generations at this point, and yet still in our communities, we know we have significant issues. So some of you have seen this picture already. This is the picture speaks 1,000 words. And so this is from a recent horrific case that we had that we worked through that was really a reminder of why all of us are here and why we continue to do the work that we do. So much like Elizabeth detailed, we started our work in response to some of the community needs assessment findings that we were seeing. And we've been really fortunate at WellSpan. I don't know if you all are familiar with WellSpan, but we cover 9 counties throughout central Pennsylvania. And we have phenomenal partners who have been doing this work for a really long time. BPMC's program being a great example, the City Bureau of Health, New York City being another example. We've leaned heavily on the New York County Planning Commission and countless other partners that I could spend 15 minutes probably listing. And so we weren't actively doing a whole lot of work just as WellSpan in this space. Nevertheless, we knew in our public health minds that we've seen the DC water crisis, we saw the Flint water crisis, we saw those headlines that said, hey, did you know that cities in Pennsylvania are reporting higher lead exposure than Flint? And so we said we really need to take an action here. We need to figure out what the WellSpan response is. If any of you have not yet read that book on the right, it's like a shameless plug. I always put this book up there, What the Eyes Don't See. Was really a monumental book for me and an aha to say, I really want to be involved in this work. So the other piece of what we looked at is we looked at lead in our neighborhoods. And we saw that the majority of our homes, more than 50% of homes throughout the WellSpan footprint are built before 1978. And so as a result, we said we really need to be paying attention. And as Elizabeth mentioned, the average of testing is around 19% in Pennsylvania. Within our area, we saw that it was fewer than 30% of children under the age of 2 have been tested for lead. So you all know this, right? So this is why we were really driven to the work. But simultaneously, as these conversations were happening, WellSpan also launched our Spotlight on Children's Health Initiative. So you'll notice the slide looks a little different because this is from the Spotlight Initiative. And right in the middle, you'll see a green box that says our signature projects. And we saw that there were 4 key projects called out, with lead being one of them, and that it also went along with children with special health care needs and bolstering our response there, increasing infant and child safety and breastfeeding, and then focusing on literacy and early childhood education. So all of us in community health said, well, doesn't that all fit together? So what a great opportunity for community health to really jump into this work and see where we can take action. There was also a very collective acknowledgement that very rarely when we're interacting with a family is housing the only circumstance or the only situation that the family is struggling with. So typically we talk about the cost of living crisis, for example, that our communities are facing, and so often we see that housing is one of many of a bunch of different challenges that our families are facing. And so we really wanted to dig in and say, how can we look at the lead issue in the context of the broader patient and the broader community overall. So you'll see here that we looked at lead exposure with context to food, housing, employment, healthcare access, you name it, all of the social determinants of health and more. So what do we do? One of the things that we did is across our region, we started talking with community partners. And we said, you all are the experts. Tell us what we need to know. What's going on with housing? What's going on with lead exposure? Help us to understand where there's gaps. What we heard is what we heard a little bit earlier this morning, which was that housing occupancy rates are astronomically high. There isn't inventory. So if you say to a family, hey, have you looked for another place to live? They're going to laugh, right? Because they have. And there are places for folks to go. There's tenuous rental circumstances, and often folks don't want to rock the boat. They don't want to raise the concern of rodents or the concern of lead paint or anything else to the landlord, because frankly there's 20 other people that would happily rent that property, no questions asked. We also saw that there was some inconsistency in the availability of lead testing, both within our facilities and beyond. That there was high demand for it, but that there was high demand for services and remediation, but low landlord motivation to make changes unless forced to. And so what we sort of did after our head stopped spinning is to say, well, where do we want to start taking action here? The first thing we did was we went bigger. We went bigger and said what we're talking about when we talk about children's lead is actually a housing-related issue. And so we did a pretty intensive lit review as a team and said, what are other people doing? What are other health systems doing with regard to investment in housing? And so we started there and we said, you know what, it's going to take a whole lot of money to make a difference in housing in our neighborhood. And we've heard, $9 million, there's lots of millions of dollars that will make a dent in things, but surely we knew that there needed to be a significant investment. And so one of the things that we have done is we at Wellspan have committed about $18 million between now and FY28 to housing related investments. And this includes $3.5 million in grants that were awarded last year. And this was our one of our approaches to say, hey, we really need to take on housing, we really need to address housing, and lead is one of many components of inadequate housing in our area. The other thing that we looked at was strengthening our clinical infrastructure. So we acknowledged pretty quickly that other health systems were doing it better, and that other health systems already have Epic tools or electronic health record tools to really guide decision making for our providers. And we said, how are we going to do that? We formed a children's-led advisory group with a few work groups and started to kind of dig in and say what needs to happen in order for us to take action. It looks like my slide didn't carry through my titles here, so I have you all on the edge of your seats. But on the left, you're going to see the yellow bars. This is for lead testing overall at Wellspan over the last 3 years. So you'll see that between July of 2022 and June of 25, we've tested just shy of 10,000 children. We're probably surpassing that right now. And so the yellow bars are showing the increase in testing overall, regardless of the type, whether that's a venous blood draw or a dry blood spot or something else. On the right-hand side, you're going to see our dry blood spot testing. So dry blood spot testing was in response to what we were hearing from our patients, which was, I don't want to take my kid across the town for a venous blood draw. Have you seen what they do to those kids? They hold them down, like we heard all of our stories. As a mom of 2 little kids, I get it, right? I don't want to drive my kids halfway across town to have a needle stuck in their arm. And so what we did at Wellspan is we're doing dry blood spot tests. So it's a finger prick. It's a much more, I call it shelf-stable, I'm sure that's not the technical term, more shelf-stable test. It doesn't have to be shipped off to the lab within 20 minutes. It can sit for a little while until the courier comes and picks it up and processes that lab sample. It has great stability. It also can be implemented by a variety of different clinicians. It doesn't require, for example, a phlebotomist. And we found that it can be point of care at the bedside, conducted for our patients right then and there, directly following a conversation with the provider. So that's been really important to us because 1, it meets the need for convenience. 2, it does not cost our patients a ton, if anything. And 3, it's directly following that interaction with the clinician and that opportunity for education. So we see the numbers go up, as you can see. I always kind of cringe a little bit when I look at this slide though, because we could be doing so much better than this. So we're hoping to continue to see these numbers climb over time. You don't have to be able to read this, there's no quiz, I promise, but one of the reason I put this graphic up here, even though it looks messy, is one of the other things that we did is we were very deliberate about saying, what's the ideal state? For our clinical teams, what do we want this to look like? From the time the patient arrives or the time the patient's born, or maybe when mom presents pregnant, what do we want that workflow to look like from start to finish? And so we started to map it out. We call these swim lanes. We also started to think about when a child is identified as having elevated lead, what happens? One of the things that we were hearing from our clinical teams is, don't make me look these families in the eye and say your child's being exposed to a dangerous neurotoxin if I can't do anything about it or I have no resource at my disposal to send families to. So we were very deliberate in saying, as we build our Epic or our electronic health record tools, we need to make sure that there's also a process so that those clinicians know how to make their appropriate referrals and connect families as needed. So this is just a couple examples of how we started to do that. Also with the acknowledgement that a confirmed blood test of 3.5 is not the same as over 45. And so we wanted to make sure that we had a process regardless of where what the test result was, how we would assign case management resources based on the level of the test, what we felt like the pediatrician and the clinical teams in their practice could handle, versus where do we need to really make a referral over to case management. And then if the blood level is over 45, what is our wraparound, arms around that patient approach look like, and how will we very quickly respond to that identified need, which we have had to do a few times. All right, the other project, and I apologize, I'm just kind of skimming the surface here because I want to be mindful of time. Other project that we're really proud of is the launch of our Get Let Out or Glow boxes. This was really an opportunity for us to say, okay, it's not enough just to have our clinicians educated, it's not enough to do that moment in time when we're interacting with the patient, that education. It's not enough to have the case management follow-up. What we really need also is that ongoing opportunity to connect with patients. Anytime a patient at WellSpan is identified as having a blood level above 3.5, within a week or so, they receive a box on their front porch. You can see a picture of it over on the right, and it includes a bunch of education as well as some items that we heard from families would be of interest to them. We were very careful so as not to make any assumptions about how someone does or doesn't clean their home or the sippy cup that they did or didn't purchase, but rather just here are some ideas of items that we know are lead-free, and these are common sources of lead. At the same time that we launched this project, we were hearing about Timu having very high lead level sippy cups, for example. So like, let's put that in a box. And just gave it an educational opportunity for us to put something at the doorstep that says we care about you, we care about you knowing how to prevent your child from being exposed to lead. We also include, you can see on the bottom left of the box, we also include an iron supplement drop, as well as all the educational materials that you see across your screen. One of the things that I've been really impressed with is that we included a postcard from our Safe Kids team that basically says, are there any safety items that you need? Do you need baby gates? Do you need gun locks? Do you need medication bags? Do you need outlet covers? What is it that you need? And we had a number of families actually take us up on that, which has been great. It's showing how activated these families are and really trying to make modifications in their homes to protect their little ones, and also to make it safer in general for their children. All right, so what we're seeing right now, however, is that we have demand beyond our funding for the glow boxes. So we had anticipated that as we would see an increase in testing, we would have an increased need for the glow boxes, but we have probably gone 200% above what we anticipated we would need for those glow boxes. So with that comes, of course, a concern about funding, which we're working on, and definitely a concern. So we continue to see the demand for that. We also are seeing more of our clinical teams kind of raise their hands and say, how do I get more involved? What is it that I can do to help, which has been really amazing. And so we're hopeful that we'll continue to see our numbers increase. We've also been very thoughtful in looking at what our inclusion criteria should look like for what we call a registry, which is allowing us to track patients over time. So if a patient has ever...
It's just when something hits. You're okay.
So our registry is anytime a patient has been identified as having an elevated lead, they're sort of flagged as a part of this registry, and it has us have the ability to really track that patient over time at an aggregate level. So we heard a little bit of mention of this earlier. If we wanted to look at what percentage of children who are identified as having elevated lead go on to be prescribed ADHD medication, for example, we'll have the ability to track that over time. So we've been building that registry, and it's been really important for us to do so. We've also been seeking participant feedback on all of the work that we've been doing and saying, how's it going? What can we do differently? And then in the context of our glow boxes particularly, we've made phone calls, outreach phone calls to recipients of the boxes to say, did you like it? What didn't you like? Did you want more of this, less of that? Which has been really helpful as well. All right, I'm just going to round it out by saying, like the other partners we've heard from, we've also served the role of a funder and an advocate in the space of children's lead. So we've allocated $105,000 to support the York County lead hazard reduction efforts since March of 24. Part of this is just the acknowledgement that other partners in our community are already doing this work exceptionally well. And so we want to make sure that we are doing everything we can to help them keep doing that work really well. In addition, I mentioned already that the City Bureau of Health and the County of York has a lead reduction program. They are phenomenal, and so we, again, have provided additional resources to support them. And then along with all of you, we have also actively advocated for, at the state level, the lead hazard reduction policy, and then the low-income homeowners and landlords resources. So we've been working on that advocacy piece as well. All right, and then another thing I always like to mention sort of at the end when we're talking about lead is we've also been seeking what we call a PCORI grant, Patient-Centered Outcomes Research Institute, which you can see now why I call it PCORI and not that. This is a largely CDC-backed grant opportunity. It is a very large grant of about $9 million that we are actively pursuing, which would allow us to do a bit of a research project by putting HEPA filters into some homes, which is proven in some cases to be an effective strategy to reduce lead exposure. It would also include an opportunity for us to have cleaning services go in if a patient chose to participate in that way, to go in and actually remove some of the lead dust and help just cleaning some of these homes that we know are very difficult to keep clean over time. So we're pursuing that now. I think we actually should get a result, so everybody cross your fingers for us. We should hear something today. So we're hoping that we get some funding in that space. All right, so the next steps, just as my last slide, we're really looking to continue to expand and evolve our clinical tools, our clinical resources. We're trying to do that without completely overwhelming certain teams within our organization. So as we increase testing, there are some folks who are doing like an astronomical amount of work, and if we keep testing, we're gonna bend them until they break. And so how do we make sure that we grow the demand, but also grow the support of these really important teams who are doing phenomenal work in helping these families? Because the last thing we want to do is bend them until they break. But truly, we don't want to just test. We want to test and then have the wraparound resources available, and we want to do that in a way that's really mindful of both our teams and our patients. And then also looking at community collaboration, that's really been at the heart of all of this work. And so we'll continue to do that and continue to advocate for this important work. That's it.
Okay, the microphone is up here.
Oh, perfect. Yeah,
Okay.
yeah.
We have about 5 minutes for questions, if anyone has a question for is this a panel, for the panelists, or presenters?
Hello, for Elizabeth. Curious, the 50 million, who is the funder? Is the hospital?
Yes.
Yes, that's the short answer. Yeah, our hospital supported it. Yeah, it's a commitment over a 10-year time period. And so we're hoping that that is beyond 10 years. But yes, it came from our hospital.
And the 50 million, how much of that goes to GHI?
I don't know the number off the top of my head. But yeah, they get a portion of it for their staff support, kind of running that. I could probably give you a percentage if you're interested at another time.
No, I was just curious. So they are sort of like a sub-grantee to your...
Yes, so they contract with us. They're a contractor.
And they handle everything from construction, and you guys just handle the intake?
Yeah, so they handle construction, so they handle like coordinating the risk assessment all the way to the clearance. Sorry, what?
We coordinate risk assessment.
Yeah, so we coordinate the risk assessment and then you get to the clearance after that,
So construction is
their main thing that they focus on.
Okay, and when you were bringing this about to your, I guess, the hospital higher-ups, or?
Yeah, so we brought it
to,
so our board of trustees was really the decision maker on this, and so our board of trustees approved, they had actually asked us to present to them community health programs for funding, because they were really invigorated by the work that we had been doing. Our department had won a national community health grant, or community health award, and so they were really energized by that and said, what else can we do? And so the lead-free program was one of those proposals, and we sort of decided to go big, and they were happy to support it, so.
Okay, last question.
Yeah.
In the hospital, how many staff do you have just working on this alone?
So myself, we've got 5.
We just hired our 5th.
5. We just hired our 5th, yeah.
Manager, supervisor, 5 employees.
Yeah.
All right, well, thank you, appreciate it.
Sure. Any other questions?
This one's for Joyce. At what point do you recommend us submitting for inspection, as far as, do you look at the lead level itself, or 2 abnormal results, or what do you prefer?
We recommend 3.5. Most of our contracted MCOs, medical assistants, will accept a capillary for us to go out. And that's more about prevention, because we're talking about a 1-2-year-old. Where else are they? They're not roaming the streets and getting, lead on their fingers. So that's where, to me, that's where prevention comes in. But let's get this and find out what it is before it gets to be a venous level. And so does that answer your question?
Yes.
Okay.
Thank you.
And then we'll do a final question before we let the other group back in, take a back hearing, etc. Does anyone else have a final question? No one? We know everything about lead now. That's fine. Yeah. Oh, yeah.
Wes has a question. Great prevention work by all of you. I just had a quick question for Stephanie. You mentioned reentry program as part of your healthcare, and is that a workforce program? How does that work with you? I saw on your slide you had a reentry program as one of your solutions.
Yeah.
How are you using reentry individuals as part of your healthcare?
Yes. So we do have a reentry program that it's probably on our housing slide. We have a number of reentry programs for prison reentry. So as an inmate is nearing the end of their sentence, for example, we have a number of different supports around them to get them back into our community into safe and affordable housing, which is very, very difficult work. Our case management team has done a phenomenal job working with a lot of local community partners to do that work. And there's a whole lot that goes into it, but sustainable wages is one piece, securing transportation, and then ensuring also that if there's going to be a family, for example, there, that we have sustainable housing that's affordable but also safe has been really an important piece.
Great. Thanks to our presenters today and to our